Hi everyone, my name is Kirsten Ackerman, and today I'm going to be discussing childhood obesity and bariatric surgery in the adolescent patient. So first, let's talk about prevalence. So 11% of 2 to 5-year-olds, 15% of 6 to 11-year-olds, and 18% of 12 to 19-year-olds are classified as overweight. The incidence of obesity among adults in the past 4 decades has doubled, but among adolescents, this 12 to 19-year-old group, it's actually tripled. So the concern here is that, of course, as these adolescents get older, the rates of obesity in adulthood are going to increase as well. And with an increase in overweight and obesity, there's an increase for chronic disease. Comorbidities that historically were only seen in the adult population are now being seen in children. So we have to kind of get this early. So in terms of diagnosis, it's a little bit more complex than it is in the adult population to diagnose someone with overweight and obesity. So the way that we do it is with these growth charts. So, children are obviously still growing and developing, and their weight can fluctuate normally. Sometimes an increase in weight simply means that they're about to have a growth spurt, or it could be that they're consuming too many calories for their needs, and it really is an inappropriate amount of weight. So by plotting their growth on these growth charts, these are the CDC growth reference charts used for children ages 2 to 19-year-olds, 19 years old. So by plotting on these charts, we can see their growth over time and kind of see whether it follows the normal growth curve. If it's in the 85th to 95th percentile, the child's going to be classified as overweight. And then if it's above the 95th percentile, they're classified as obese. So a rapid increase in weight without an increase in height, again, might indicate the child's consuming too many calories, or it could indicate that they're about to have a growth spurt. So by monitoring it over time, you can kind of see the trend. So now we're going to discuss some of the risks and comorbidities of childhood obesity, because this is really where the concern is. So children that are overweight or obese are going to be at higher risk for high cholesterol, which in turn puts them at risk for developing cardiovascular disease. They're also at risk for high blood pressure, which puts them at risk for hypertension. They're at risk for high blood glucose, which puts them at risk for type 2 diabetes. And the problem with having type 2 diabetes early on in life is that the longer you have the disease, the more likely you are to have some of the severe complications, like neuropathy. So of course, if you're getting it in childhood, you're going to have it for a long time, and there's a higher risk for developing those complications. Other risks associated with childhood obesity include hormonal imbalances in girls. So this could lead to early menses, and this puts the child at risk for developing certain types of cancer. And then, of course, there are the psychosocial disadvantages. Overweight children are not as well accepted by peers as normal weight children. And this can be really traumatizing for the developing child. So this is where weight loss surgery has come in, and it has become increasingly accepted as a modality for treatment in adolescent obesity. And it has been found to surpass lifestyle modification at reducing BMI, improving comorbidities, and raising quality of life in this population. It is not acceptable to perform bariatric surgery on a patient that has not reached full physical maturity. But other than that, it's indicated in many cases. So now I would just like to talk about some of the surgeries. So the one that's currently accepted for use in the adolescent population is Roux-en-Y gastric bypass. And this is really the gold standard of weight loss surgery. So in this surgery, a small pouch is created of the stomach, and the remaining stomach is left in the body, but it's not used. In other words, it's bypassed. Some of the digestive enzymes still are secreted and can go in further down on the digestive tract. But in terms of where the volume of food is going to go, it's going to be in that small pouch, which severely restricts the volume. In this way, it is a restrictive procedure. It's also a malabsorptive procedure in that a large portion of the digestive tract is being bypassed. And this distal part of the small intestine is attached to the pouch of the stomach. So this is the only surgery that's currently approved for use in the adolescent population. But in the experimental phase, there is this other surgery, which is called the gastric sleeve. The gastric sleeve is just a restrictive procedure. So this outer part of the stomach is actually removed from the body, and the patient is just left with the so-called sleeve of a stomach. So it's a larger portion that would be left in the gastric bypass, but it's still much smaller than the full stomach. Okay, so that is just a restrictive procedure, again, called the gastric sleeve. The other procedure that is done in adults and that may be used in adolescents in the future is called the adjustable gastric band. So in this procedure, nothing physically is changed about the body other than this band, this gastric band is placed, and the band you can either put fluid in or remove fluid to kind of adjust and see where what works best for the patient. It really varies per case. But the band is placed, and basically the volume of food that is going to be allowed in the stomach at one time is going to be restricted. It is reversible. The band can be removed. This port is where the fluid is either put in or taken out of the band. This is a procedure that is used widely in the adult population, so it may at one point be used in adolescents. So again, this is the Roux-en-Y gastric bypass, that gold standard of bariatric surgery, which is approved. And then still under investigation, under review, are the adjustable gastric band and the gastric sleeve gastrectomy. So now let's discuss some of the indications for surgery in the adolescent patient. So first, they do have to have reached full physical maturation. If surgery is performed prior to that, linear growth could be stunted due to the fact that this surgery will cause or can cause nutrient deficiencies. So they really have to have reached that full physical maturity. And the second indication is going to be this BMI criteria. So it varies based on the practice, but in general it's going to be that the patient has to have a BMI somewhere in the range of either greater or equal to 40 or up to 50 or so. And they have to have, in most cases, they do have to be presenting with comorbidities, although some practices will not necessarily require that if the BMI is high enough. But some of the comorbidities that will qualify a patient are obstructive sleep apnea, non-alcoholic fatty liver disease, type 2 diabetes mellitus, and then impaired quality of life. The exclusion criteria are actually pretty limited, especially some of them, if they're controlled, then the patient could undergo surgery. But the exclusions include uncontrolled depression, uncontrolled disordered eating, pregnancy, which would pose, bariatric surgery would pose risk to both the mother and the child. Prader-Willi syndrome, which causes uncontrollable hunger. So this obviously would not be resolved by having the surgery. So this is an exclusion criteria. And finally, some practices will state that if the person lives at a long distance from the bariatric surgery center, that they cannot undergo surgery. And this is just because, especially in the adolescent patient, it is so crucial to have that post-op long-term follow-up with the patient. So finally, I would just like to discuss some of the pre-op requirements that the patient has to undergo prior to surgery. So first, the adolescent patient needs to undergo a psych evaluation just to kind of evaluate their mental state and whether they're at a mature level to be able to make this decision to undergo surgery. But further, they also have to be evaluated for any signs and symptoms of depression, which could be exacerbated with surgery. They also have to undergo a nutritional screening to assess their nutrition knowledge and their ability to follow the post-op guidelines, and also to assess if there are any nutrient deficiencies present that would have to be corrected for prior to surgery. The adolescent does need to demonstrate an ability to comply with post-op guidelines. And finally, they have to give informed consent. So this really should consist of an in-depth counseling session where the adolescent is given the risks and benefits in detail of having this surgery. So that does conclude my presentation today. Thank you so much for watching.